Hi, everyone. I'm Jordana Topp, the Yoetzet Halacha for Beth Jacob Congregation in Beverly Hills. Thank you so much for joining this evening. I hope you're all enjoying the conference. Thank you to Nishmat and Mizrahi Canada for putting together an incredible and much-needed program. Pain associated with womanhood has a long history. It goes all the way back to Chava, the first woman, who was punished by God after eating from the Eitz Hada'at. Harbe arbe itzvonech veheronech be'etzev teldi banim. I will greatly increase your suffering and your childbearing. In pain shall you bear children. Some degree of pelvic pain related to menstruation, certainly the birth process, is so prevalent, it's considered normal. It's usually either tolerated or treated with medication. For some women, however, menstrual pain is severe, beyond what is considered normal. Some women may have other symptoms as well, such as painful sexual relations, GI symptoms, or unexplained infertility. Today, we have the privilege of hearing from Dr. Iris Orbuch, a gynecologist who specializes in minimally invasive surgery. She's an expert in endometriosis, author of Beating Endo, How to Reclaim Your Life from Endometriosis. Dr. Orbuch is at the forefront in her field, educating both the medical community and her patients about endometriosis. You can read more about Dr. Iris Orbuch's impressive resume and her accomplishments if you click on her bio, which is below our screen. Personally, I met Iris when she moved to LA with her husband, Dr. Larry, who she practices with, and their fabulous daughters in 2017. I'll admit that when I first heard that Iris and Larry practice endo, I was a little bit confused. Personally, professionally, I'm a dentist, and in my world, endo is short for endodontist, someone who specializes in root canals, but every field has their lingo, and tonight, endo is short for endometriosis. The Orbuchs have been a great addition to our community, and we're so fortunate to have them as our dear friends. Iris is the star of our show tonight. She will be educating us about endometriosis. I will interject with some questions, the relevant halachot, and the impact on Taharat HaMishpacha. We will take some Q&A. Hopefully we have time at the end. I ask, please only ask general questions, no personal inquiries. And now, Dr. Orbuch, take it away.
Thanks, Jordana. So first of all, I want to thank both Nishmat and Mizrahi Canada for recognizing the implications that endometriosis has in our Halachic community. And secondly, Jordana, I really would like to thank you. You're a dentist, a Yoetzet Halacha. You're the Rebbitzin of our Beth Jacob community, and you wear so many hats, and I could not think of anyone better suited to partner with to tackle this topic. So thank you.
Thank you.
All right, I'm going to share my screen and we'll begin. All right. So our topic is entitled Pelvic Pain, Painful Periods, Unexplained Infertility, Endometriosis, and its Halachic Implications. So let's just start off with just some broad objectives. And I'm hoping that by the end of this talk that you'll recognize that endometriosis is so much more than painful periods. We're going to talk about up-to-date evidence-based approaches to endometriosis in teens and adolescents and women. By the end of this talk, you're going to understand that 70% of teens who experience painful periods have endometriosis. We're going to find out that 40% of unexplained infertility is due to endometriosis. We're going to learn that close to 80% of those with endometriosis also have another pain generator in addition to endometriosis that contributes to their pain. We're going to talk about how endometriosis is not only a disease of lesions or implants that we excise and cut out, but that those lesions are also inflammatory as well. And we're going to finally conclude that surgical excision of endometriosis is the gold standard for treatment, not ablation of endometriosis. So typically when I give lectures, and I love lecturing, and I usually am very interactive with an audience, so it's quite difficult to do virtually, but I'm going to just engage the audience and have you just throw out an answer, true or false, to the following. So first of all, true or false, endometriosis cannot occur in a teenager. Only older women get endometriosis. False. Birth control cures endometriosis. False. Medical treatments cure endometriosis. False. Girls or women should wait to have surgery until they're ready to have children or of childbearing age. False again. Pregnancy cures endometriosis. False. Ablation of endometriosis and excision of endometriosis are equally effective. False. And lastly, the treatment of endometriosis is hysterectomy or removing a uterus. These are all false. Back in 2017, our American College of OBGYN president released a press announcement, and he entitled it, "It's About Time," or "It's Time We Talk About Endometriosis." And in it, he spoke about how it takes roughly 10 years from when women first experience their symptoms until they receive their endometriosis diagnosis. That's a decade. He went on to say that roughly 40% of all women with infertility have endometriosis. And then next in the yellow is quite shocking. 63% of general practitioners, he's referring to general OBGYNs, feel uncomfortable diagnosing and treating patients with endometriosis. And as many as half are unfamiliar with the three main symptoms of the disease. Lastly, in the blue at the bottom of the slide, he concluded early endometriosis diagnosis and treatment lead to better outcomes. Careful listening and discussion are integral to early detection, and many common symptoms are not so obvious, such as chronic lower back pain and intestinal problems like diarrhea, constipation, bloating, and nausea. So I'd like to start with a kind of a fictitious patient, MG. So MG is a 25-year-old who has a 10-year history of worsening menstrual pain, heavy periods, back pain, as well as pelvic pain throughout the month. She was started on oral contraception by her gynecologist, which helped manage her heavy periods, but didn't put a dent in her pain. Her symptoms have been gradually worsening since high school. She's newly married for 6 months and has been experiencing painful relations, making it challenging for her to achieve her goal of getting pregnant. Upon questioning, MG reports that she has chronic constipation, bloating, as well as a stomach pain since she was roughly 10, 2 years prior to starting her menses. She, quote, strains on the toilet for roughly 10 minutes, 2 to 3 times a day. She's seen multiple gastroenterologists and has had a full workup, all of which was negative, and was diagnosed only with irritable bowel syndrome. Upon questioning, MG reports that she experiences a squeezing sensation around her rectum, and sitting for extended periods of time is painful. She says that she has to contort her body to have a bowel movement and confides, "I often curl up in a ball due to pain." She adds it hurts to put a tampon in and now relies only on pads. She experiences both pain at the onset of penetration during relations, as well as with deeper penetration. All imaging has been normal, including CT scans as well as ultrasounds. So let's talk about the symptoms of endometriosis, because the symptoms of endometriosis really go from head to toe. So in terms of gynecological symptoms, one could have painful periods, painful sex, heavy periods, suffer from infertility. They can experience pain any time of the month. It can be preceding one's menses, after one's menses, during ovulation, during one's period, or all month long. In terms of urological symptoms, they can have pain with urination. They can have urgency where they feel the sudden urge to urinate, or urinary frequency where they feel that they have to constantly urinate. Some experience endometriosis pain as back pain. Others have right-sided pain, and others left-sided pain. GI symptoms are so common in endometriosis, occurring in 90% of adults and roughly 50% of teenagers with endometriosis. Some experience bloating, others have constipation, others more diarrhea. Some have alternating diarrhea and constipation. Many have painful bowel movements, nausea, and vomiting. Overwhelmingly, just about every patient experiences fatigue, not just plain fatigue, but debilitating, disabling fatigue. I wanted to note that everyone's symptoms of endometriosis is completely different. I have many sisters in my practice. I have many mother-daughters in my practice. And where one sibling can have predominantly gastrointestinal symptoms and perhaps painful periods, the other sibling can have urological symptoms, not have painful periods, and just have heavy periods. If they happen to have a triplet, that one may not experience any pain whatsoever, but only experience infertility. And in 2003, Fred Howard, who's now long retired, a big guru in pelvic pain, he published an amazing paper, and he said, when taking a patient's history, it's critical to ask questions not only regarding pain, but also asking urological, GI, musculoskeletal, and reproductive system questions when talking to suspected endometriosis patients. And to me, it blows my mind that we're in 2021, and I've been practicing post-fellowship roughly about 17 years, and still it takes nearly a decade for someone to obtain the diagnosis of endometriosis. And typically they see almost 8 physicians over the course of that decade until they're diagnosed. If anyone read his paper or heeded his advice, we'd be picking up endo so much sooner. Chip Buttrick, another guru in the pelvic pain world, recognized that close to 80% of endo patients also have an additional reason to have pain. So for me, as a gynecologist, we need to identify all the different reasons why women have pain. We need to then treat each one of those pain generators. And we need to work together with pelvic floor physical therapists, urologists, pain psychologists, pain specialists, gastroenterologists. Really a multidisciplinary approach is necessary, especially because there's such a delay in diagnosis. Now, we're talking about endometriosis today, but those with endometriosis can have an increased likelihood of all of these entities. I've placed pelvic floor dysfunction in red because I'm going to touch on this, but just to understand that those with endometriosis have a higher likelihood of having Hashimoto's thyroiditis, a higher likelihood of having irritable bowel syndrome, also higher likelihood of lupus, eczema, interstitial cystitis, anxiety, depression, celiac disease, fibromyalgia, central sensitization, which is just a really flared central nervous system, small intestinal bacterial overgrowth, pudendal neuralgia, and allergies and sensitivities. So for any of you who are out in the audience listening to this, or you know someone, a family member or a friend who maybe has been diagnosed with one of these, because each one of these diagnoses are very easy to make because they're often, we rely on blood testing or imaging to make these diagnoses. But if some of the symptoms that I'm speaking about tonight resonate with you, you may also have endometriosis. So JM was ultimately diagnosed with endometriosis and pelvic floor dysfunction. So let's start talking about what is endometriosis. I always like to start with a scientific definition, which is the presence of ectopic endometrial glands and stroma. But what does that mean? I promise I'm going to make it so simple And by the end of this talk, you're going to be able to know a lot more than just about every gynecologist in the country, or rather in the world. So if this is a cartoon of the uterus, and I want to just start to get you oriented into the female anatomy, because I'm going to show you some videos. If this is the uterus, to the left is the left fallopian tube. This white area is the left ovary. On the right side, this is the right ovary and the fallopian tube here. This is an area behind the cervix. And what's within the blue box is enlarged here. And this is all endometriosis. You all are going to become experts at diagnosing endometriosis by the end of this talk. So the way that I explain what endometriosis is to my patients, I'm a visual learner, that's how I made my way through medical school, is I typically will draw my patients a picture. So this is a cartoon of one's uterus. We have an ovary and the other ovary here. This is the cervix where we have pap smears, and then this is the vagina. So right in the inside, this is the endometrium. That's the lining of the uterus that gets thicker and thicker and thicker until we withdraw bleed and get our menses or get our period. Endometriosis is when we have cells that are not identical, but they're similar to the endometrium, but they're simply found external or outside of the uterus. So I'm going to try in my next, couple drawings. And I know that, when my kids were 4 or 5, they could draw better than I could in these pictures, but I think it does the trick at illustrating what endometriosis is. I'm going to try and draw a cartoon of the pelvis. So in front, we have our bladder. Anatomically behind our bladder, we find our uterus, and behind that is our rectum. So endometriosis, again, is when we have cells that are similar to the lining of the uterus, but those cells are found external or outside of the uterus. So in this case, this is trying to depict endometriosis, which is in front of the rectum, behind the uterus. Endo can be sandwiched between the bladder and the uterus. Honestly, endometriosis has been found in every organ of the body but the spleen, from head to toe. It's been found in brain, it's been found in lung, it's been found in muscle. But nevertheless, what happens every month when our ovaries tell our uterine lining or our endometrium to get thicker and thicker and thicker, it does. And then when we get our menses, we shed that lining. The hormones also from our ovaries tell these endometriosis implants so too to get thicker and thicker and thicker. The problem is in the pelvis that there's no exit point. So month after month after month after month, these implants get deeper and deeper and deeper, and they start to distort the anatomy, pulling things to the right or to the left or the back, and then subsequently pulling on the underlying layer of the muscles and the fascia. So let's talk about some facts. Endometriosis affects at least 10% of women, and that equates roughly 200 million women worldwide. That's a crazy number. And teens often present with acyclic pain, meaning their pain isn't only occurring during their period. Often it's happening at other times of the month. 56% of adolescents already have at least one GI, gastrointestinal symptom, and 52% of adolescents already have one urological symptom. What's important to know is that the laparoscopic appearance of endometriosis in a teen is completely different than in adult women. And we know that endometriosis is found, some studies say 40%, others say 50% of those with infertility, and only surgery enables a definitive diagnosis. So because of the variability of symptoms, the time from symptom onset to diagnosis in the United States is 10 years. And the reason it's 10 years is because the symptoms can cross all different organ systems. Some are GI, some are urological, some are fertility, as well as the fact that endometriosis is not seen on pelvic ultrasound. It's not seen on CT scan. You can run yourself through any radiological imaging test and it will not show endometriosis. We need to suspect it as a physician by asking the right questions, as well as my physical exam. And we know that the gold standard for diagnosis, which means how we as physicians diagnose endometriosis, is by seeing an entity that looks abnormal during laparoscopy, removing it, then sending that piece or specimen to the pathologist, the physician who looks at it under a microscope. Then they render the diagnosis, hey, that's endometriosis. And I want to show you the varying appearances of endometriosis at laparoscopy. And the reason that I want to show this to you is because I did 4 years of general OBGYN residency prior to initiating my fellowship which was in minimally invasive surgery, and it was primarily focused on endometriosis. In my first week of fellowship, I learned more about the varying appearances of endometriosis than I learned in my 4 years of residency. So I could show you 30 different appearances of endometriosis. Just for the sake of time, I'm going to just start by showing you a few. So this is a laparoscopic view, and I'm looking at the cover of the bladder. So what happens initially, let's say this is an implant of endometriosis. What happens is our body starts to increase more and more blood vessels, more blood supply to help grow and nourish that endometriosis implant. So typically when I find this increased vascularity or all of these blood supplies in a certain area, that's a tip-off point that there may be endometriosis there. Endometriosis can be brown. Endometriosis can be black. It can be red. This is the only appearance. This is endometriosis on an ovary. This is a chocolate cyst of endometriosis. This is another ovary with some endometriosis externally on it. This is the only appearance that I learned in my 4 years of OBGYN residency. Next, I know this is a bit of a confusing picture, but my surgery that I'm going to show you all is going to show, this is the back of the cervix, and this is a left uterosacral ligament and a right uterosacral ligament. And I'm not sure if you can appreciate that the diameter of this left uterosacral ligament is much smaller in caliber than the right uterosacral ligament. Both of these are actually infiltrated with endometriosis. And since you're experts now at identifying red endometriosis, I'm sure you can identify that there's endo here and endo right in here with this increase in vascularity. Now, with endometriosis, patients often will say, oh, it hurts when I have relations, or it hurts when I have sex. And I typically will query them and I'll say, is the pain on penetration, initial penetration, or with deeper penetration? Typically, the initial penetration discomfort or pain is in reference to the muscles, which I'm going to talk about it later. The deeper penetration pain is because of endometriosis in this area. We call it in the cul-de-sac or the uterosacral ligaments, because what happens is the penis is pushing in this area.
Dr. Orbuch, can I interject a question
Sure.
here? So some of us in the audience, including myself, are Kala teachers. And thankfully, in the last number of years, there's been more education for Kala teachers in the area of pelvic floor health. And we're taught to look for certain red flags in women that we're teaching either before their wedding or when they're newlyweds. Red flags such as difficulty using a tampon, or pain when doing internal examinations, the petticoat, or after they're married, difficulty consummating the marriage. And we're taught to refer women to PT, to physical therapy, specifically to pelvic floor specialists. And now that we're learning about endometriosis, my question is should PT be the first stop? Should we be adding an endometriosis specialist to our list of referrals? You know, what should a Kala teacher know to do?
So it's a great question. So even in my practice, so typically muscles get tight subsequent to something else. So if someone is in excruciating pain or they're assuming a fetal position all the time, what happens is secondarily, the pelvic floor muscles get tight. So my first stop for my patients, they come in, we have a really extensive initial consult. It's usually an hour and a half, often 2 hours. And I explain to them, and I say to them, based on your history, based on your physical exam, I do suspect you have endometriosis, but because of this diagnostic delay, because you've been curled up in a ball for 10 years, because you've been constipated and straining and pushing your stool out and further tightening those tight muscles, my first stop for my patients is pelvic floor physical therapy. With that being said, I typically like my patients to get 6, 8, 10 pelvic floor PT one-on-one 1 hour sessions with a skilled pelvic floor physical therapist, and then I typically will operate on them. So I think, to answer your question, I do think that sending them to pelvic floor PT right off the bat is just the best gift you can give them. However, mentioning that, asking them about other questions relating to the GI symptom, the urological symptoms, and saying, listen, I think that endometriosis may be at the root of your tight muscles. You may want to find an experienced gynecologist who specializes in endometriosis.
Of course, a college teacher would never diagnose a disease,
Right.
but just refer and maybe alert them to their, to make them aware of what's out there. Thank you.
Great question. And now the next picture I'm going to show you is going to be a segue into teen or adolescent endometriosis. So this right here in the center of the screen is the uterus. And this little dot here and here that's found within these orange circles is how we find endometriosis in teenagers. And it's found as clear vesicles. And I never learned this when I was in residency in my 4 years. We did hundreds and hundreds, probably thousands of laparoscopies. And I never was taught this. And the beauty of our advancing modalities for surgery, I've been doing robotic surgeries probably for the last, 8 years or so. And robotic surgery affords a 3D high definition visualization. And it really allows us to pick up these clear vesicles that are found in adolescents. And I wanted to share something really interesting about endometriosis in fetal tissue. And there was a study that took a look at female fetuses who unfortunately didn't survive. Let's say they were a subject of blunt trauma during a car accident. There were then these pathologists who took all the female fetuses and they did autopsies on them. And they found that 9% of the female fetuses actually had endometriosis. And the reason I'm bringing up this extraordinary paper is to understand, as I mentioned in a prior slide, that roughly 10% of women have endometriosis. If there is a family member, it could be on the maternal side, it can be on the paternal side, who has endometriosis. It could be a sibling, it could be an aunt, it could be a grandmother, it could be a cousin. We know that young girl has a 7 to 10-fold higher likelihood of having endometriosis. So that literally means they have a 70 to 100% likelihood of having endometriosis. So this study is really showing that there's two mechanisms of transmission. One, there's a genetic component, right? It's being transmitted down. And we know when the fetus is in the mom's uterus, if there's exposures to dioxins, which are byproducts of bleaching, and there's probably many other exposures that we don't know of yet, then that the fetus can develop endometriosis. Now, endometriosis, for whatever reason, has been very neglected and not spoken about entity. But luckily, over the last few years, this has begun to shift. And in our OBGYN news, one of our articles, they spoke about how the push is on to recognize endometriosis in adolescents. And in the blue highlighted area, it talks about how the majority of women with endometriosis, roughly 2/3, report first experiencing their symptoms in adolescence. And it concluded that if we can diagnose endometriosis in early stages, we can prevent a lifetime of pain and suffering and decrease rates of infertility, hopefully stopping disease progression before it does damage. So for all of the moms out there, or hopefully there's some healthcare professionals or teachers or college teachers, it's important to understand that adolescents can have endometriosis. 64% of adolescents have painful periods. 44% of these adolescents have heavy bleeding. And as I mentioned before, roughly about half have intestinal symptoms and roughly half have urologic symptoms. And that adolescents are more likely to have non-cyclic pelvic pain. This is such an interesting study. What it found was endometriosis is found in 70% of girls or teens who have painful periods. So let's say there's a young teen who's suffering from really painful periods. At that moment in time, she has a 70% likelihood of having endometriosis. And lastly, we know that timely referral to a gynecologist experienced with laparoscopic diagnosis and treatment of endometriosis is critical to expedite care for adolescents with pelvic pain.
Iris, one question I have is, as a parent, if your daughter does experience severely painful periods, how do you know, though, what is normal? They say that teenagers sometimes have more severe cramps, and then, as their bodies acclimate, after a few years, then it's less severe. So how do you know what's considered normal? You can control with ibuprofen or combination with acetaminophen, and when they need to see a specialist. And if they do need to seek further medical care, the first stop the pediatrician, the gynecologist, or straight to an endo specialist?
Yeah. So the way that I explain it is, if your child loves theater and they look forward to trying out for the play all year long, and when that time comes in that academic year, they decide not to try out because they're in too much pain, or if they're a big cross country runner and they love running, but they don't even want to try out for the team this year, or you have a social kid and your social child keeps withdrawing or not engaging or saying no to those sleepovers with their friends because they're afraid they're going to get their period during that time. So essentially, if your child is curling up in a ball, whether it's in their bed, it's on the bathroom floor, and they're not doing those things that they absolutely are so passionate about, I think that's a good key that they take them to see a physician. Now, the question is, who is going to recognize endometriosis? As I mentioned, I did 4 years of OBGYN training, and everything.
Iris, I think your sound went off. It's back.
You hear me?
It's back. Yeah.
Okay, great. So,
I would love to say take them to the pediatrician. They'll know exactly how to diagnose, manage someone with painful periods, but it's so sad that they don't. And I would say, and I'm going to give references at the end of the presentation, where you can find experts in endometriosis, no matter where in the world you are. There's a Facebook group called Nancy's Nook that it's roughly about 130,000 members, and it's an online self-directed educational resource, probably one of the best resources that is there. And there's a heading on there, like find a physician, and it lists physicians who are specialists throughout the world. So I would not go the route of the pediatrician or the gynecologist. I'm hoping things are changing. We're trying to do so much education, but right now you're just going to lose a lot of time and probably be armed with wrong information.
Wow. Thank you.
And I just wanted to bring this up to show that half of teens have GI symptoms, but in adults, 90% of adults have gastrointestinal symptoms. And often in my practice, I see that adults come in and they're referred by a fertility doctor for infertility, and they come to my office and they say, I don't know why I'm sent here. I don't have any of the symptoms of endometriosis. And then I ask them questions about bloating, constipation, diarrhea, and they literally are like, yes. All right.
Well, now that we learned some background about endometriosis, how can endometriosis affect a marriage? So it clearly affects a person in terms of having chronic pain. Anytime a person's in pain, that causes stress on a relationship, not just a marriage, any relationship that you're in. When you're in pain, you can't function normally. Women may have feelings of guilt. They might feel like there's something wrong with them, or maybe their pain used to be just their own personal pain, but now they're married and they can't have relations with their husband, and that's causing stress. They might feel guilt. They might be angry at their spouse. Why is it just me? My spouse doesn't understand what I'm going through, or it's just my body. They might feel very lonely. A lot of women don't talk about these things. Certainly, painful relations is not something that's spoken about very often in the public. Women may become depressed, as Iris, I think, mentioned, that depression very often goes along with these symptoms. Painful intercourse can certainly affect a marriage. It's supposed to be a feeling of uniting with your spouse, and if it causes pain, that's the opposite of what it's supposed to be. Heavy bleeding or mid-cycle staining can lead to more days of nida and more physical separation for couples who are observant. And certainly, difficulty conceiving can certainly impact a marriage if endometriosis leads to infertility. So all of these things can just really negatively affect a marriage. So what can I do about it? Aside from going to see Dr. Orbuch or another endometriosis specialist, in the meantime, educate yourself and your spouse about endo. You can get Dr. Orbuch's book, which I think is going to be available on the raffle. We're going to give the little code at the end, but read her book, educate yourself, educate your spouse. The pain is not in your head. This is not something that's fabricated. It is real. Don't ignore your symptoms because they won't go away on their own. Communicate. Share the journey. It makes it much more tolerable, less isolating. with your spouse, with loved ones, the trusted friend. Don't suffer in silence and expect your spouse or loved ones to read your mind, because they just can't. Do get help early. Don't wait years before seeking help. The more pain generators that you develop, the harder it is to undo that cycle of pain. And in the meantime, couples need to find alternate ways to enjoy physical intimacy if intercourse is off the table for now. And certainly don't say something feels good when it doesn't. Sexual relations always have to be consensual, even in a marriage, and a woman should never tolerate something that's painful. So those are some things to keep in mind.
Thanks, Jordana. So I want to talk a little bit about medical management, and something that I want to kind of drive home this point is that medical management doesn't cure endo. It doesn't treat endometriosis. All it does is it suppresses the symptoms of endometriosis. So if someone has one of their symptoms of endometriosis is really heavy menstrual bleeding, medical management, we'll talk about the different ones. It may lessen the heavy bleeding, but just so you know, the disease of endometriosis continues to progress. Or if someone has really debilitating periods, medical management like the birth control pill may lessen that pain, but the process of endometriosis continues to ensue. So there's the oral contraceptive pills, and I'm going to talk a little bit more about that on the next slide. There's a medicine that's FDA approved called Lupron. It was initially used for prostate cancer, then it found its applicability for endometriosis. I have to tell you, I don't think I've ever written a prescription for it. I have 2 daughters. I would never give my daughters this medicine because on top of all of the horrific endometriosis symptoms it causes, it essentially puts one in a menopausal state. Hot flashes, weight gain, joint pain, muscle aches, osteopenia, which is weak bones, osteoporosis, which is, you know, what we think of when we see an 80-year-old walking hunchback down the street, and depression. And there's really a limited time that someone can be on these medicines. And then when you go off of the medicines, typically a lot of these side effects continue. Orlissa is somewhat of a newer medicine. Its net effect is similar to Lupron. It's also FDA approved. It's an oral version, while Lupron is a pill version, but the net effect is the same, putting someone in a menopausal state. In addition to all those side effects that I had mentioned, hot flashes, weight gain, joint pains, muscle aches, osteopenia, osteoporosis, depression, there's suicide. And just about every one of my patients who's seen 8 physicians over a course of a decade, and mind you, I have many patients who've been searching for answers for 20 years or 30 years. I would be depressed if I was searching for that long. So a lot of these medicines, the side effects really, the side effects outweigh any benefit. And then the progesterone releasing IUDs, there's a few different ones. I find that those to be the most beneficial when someone has heavy bleeding. I want to just talk about the birth control pill in terms of medical management. Again, it's just treating the symptoms while the disease progresses. But if I could tell you, just about 100% of the patients, by the time someone gets to me in my office, they've been searching for answers for a decade or 2 decades. And they'll come in saying, I've tried 6 pills, I've tried 8 pills, none of them work. And I challenge those providers who actually prescribe them to spend like 3 minutes counseling the patients as how to best take them. It's so important to take the birth control pill at the same time every day, because the idea behind birth control pills is that we want a steady state of medicine. So birth control pills have estrogens and progestins, and we want a steady state. If someone's late taking the pill, and today many of our birth control pills are on the lower side, if someone's late, even a half an hour, what happens, that causes the estrogen and progestins to dip. And what that does is that signals the uterine lining to shed and to cramp and to cause pain. So I encourage, whether it's my teenagers or my older adults, to set their phone alarm as a reminder. And if you are going to take your pill in the morning, but you sleep in, let's say, on a Sunday, then the morning is not a good time to take the pill. I think typically most people eat dinner roughly around the same time, and that usually is the best time for my patients. And I say, let's say you want to take your pill at 6 p.m., set your phone alarm at 6, 6:01, 6:02, 6:03, 6:04, 6:05. And I encourage my patients to set their phone alarm to the most obnoxious sounding alarm. I think the sonar alarm, the one that goes, to me, it puts me back into my residency with my beeper going off. So I wouldn't miss taking anything if I heard that go off once. But most of my patients typically end up taking the pill within 2 or 3 minutes by incorporating this technique. And I can't stress enough that it is normal to have spotting for the first 3 to 4 months on a new birth control pill. So please, please, please be patient. The best pills for symptom relief with endometriosis are the monophasic ones, not the triphasic. Tri, as 3 denotes. Tri means there's 3 weeks of the pill and there's 3 different dosages. That does not work well at all. So like orthotricycline is a triphasic. We don't want to use those for endometriosis. We want a monophasic. Mono meaning the same dosages of the estrogen and progesterone. And most pills on the market are 21/7 pills. What that means is there's 21 days of hormones and 7 days of a pill-free week. The best ones for endo patients are the 24/4 regimens. That means 24 days of the same doses of the estrogen and progestins and 4 days off. And then I typically will switch my patients to a continuous only pill after they don't have spotting for 2 or 3 months on the cyclic pills.
Okay, since Dr. Orbuch is talking about staining, it's a good time for us to review the laws of staining. For women on oral contraceptives who experience staining or any mid-cycle staining or following a procedure, a gynecological procedure that might cause some staining afterwards, it's important for a woman to know how to avoid becoming a nida from the staining. So our source here, which I'll just kind of paraphrase here from Masachet Nida 58b, records the following incident where a woman came before Rabbi Akiva and she said to him, "I saw a blood stain." And he said to her, "Perhaps there was a wound on your body." And she said, "Yes, there was a wound and it healed." And then he said to her, "Was it perhaps a wound that could reopen and bleed?" And she said, "Yes, it was." Rabbi Akiva ruled that she was tehora, she was ritually pure. Afterwards, Rabbi Akiva noticed that his students were looking at each other, wondering why he ruled leniently in this case. And Rabbi Akiva said to them, "What in this matter is difficult in your eyes? The reason I ruled this way is that the sages did not state that a woman becomes impure from a bloodstain in order to be stringent. They instituted it to be lenient." And he quoted from the pasuk, "V'isha ki tiyeh zova, dam yeh zova b'bsara," the pasuk from Vayikra that teaches us about nida. If a woman has a discharge, her discharge is in her flesh is blood, from which it's derived that by Torah law, blood deems her impure, but not a stain. Impurity from a blood stain was instituted by the rabbis, either to protect the Torah laws, they often do, or because of the laws of tum'ah and tahara, purity and impurity, but they rule leniently on cases where the stain can be attributed to another source. So what is a stain? It's a complicated question. One page earlier in the Talmud, we learned that in order for a woman to beat Tme'ah Nida on a Torah level, the bleeding must be accompanied by some sort of a sensation, a hargasha. And if there's no sensation that the blood came out, she may become Nida, but only on a rabbinic level. We generally define a stain as blood that you simply find, whether it's on a garment, on your body, that may have come from the uterus, and it came out without a hargasha. Next slide, please. So since becoming Tme'ah from a stain is rabbinic, the rabbis built into this gezerah, into this decree, built-in leniencies into the law, such as the one that Rabbi Akiva cited. Perhaps we can attribute it to something else, to a non-uterine source. Other leniencies include the size. Is it smaller than halachic gris, about the size of a US penny? So anything smaller than that size, we can disregard and does not make us Tme'ah. Always, only the color red. It has to be the color of blood or black is tameh. If it's a light brown, like coffee with milk, that's pure. If it's a medium dark brown, these are questions that should be asked to a halachic authority because those are tricky colors. Sometimes it's more reddish, sometimes it's not, and there's different opinions about brown. Speaking of asking questions, in all of these areas, it's really important to have someone that you feel comfortable to ask questions to. A halachic authority, whether it's a rabbi or a Yoetzet Halacha, but it's really important to be comfortable. Just like being comfortable with your physician, you need to be comfortable to ask these personal questions. Other leniencies, if a stain is found on a colored garment, then it does not render a woman a nida. if it's found on something that can't become ritually impure, it's not mikabel tum'ah, such as something synthetic, disposable, or something attached to the ground, that's also a further leniency. And the one that Rabbi Akiva cited, can you attribute the stain to something else? Each one of these leniencies stands independently. So you only need one of these in order for the woman not to become tamea from the stain. You don't need all of them. Okay. Go ahead. Okay, so outside of staining, because Dr. Orbuch told us that the gold standard for treating endometriosis is surgery, and she's going to teach us more about that pretty soon. But we want to talk about after surgery, does a woman become tamea from that? So we need to look at this source in Masachet Nida 16a. It's a statement of Rabbi Shimon ben Gamliel, Detanya haro'eh dam machmat makah, afilu betoch yemei nidata tehora, divrei Rabbi Shimon ben Gamliel. It was taught in a Braita with regard to a woman who sees blood due to a wound in her pubic area, even if she saw the blood during the days of her menstruation, meaning the time that she's expecting her period, she's pure, as it is assumed that the blood came from the wound. This is the statement of Rabbi Shimon ben Gamliel. So wound blood does not make a woman a nida. Go ahead. And what does it mean in the pubic area? The Gemara tells us that ne'emenet isha lomar maka yeshli b'makor, from the uterus itself, shemimena dam yotzet, divrei Rebbe. A woman is deemed credible to say, I have a wound in my uterus from where the blood is emerging. So if a procedure is done that causes bleeding, but it's wound blood, that's going to be tahor. However, as Dr. Orbuch will tell us, sometimes it's difficult to discern if something is a wound or it's inducing hormonal bleeding, such as in procedures for endometriosis, fibroids, other things that can come up that have both a wound component and a hormonal component. So questions always need to be asked, but that's some of the background for it. Go ahead. So when there's surgery after a procedure, there's a possibility of becoming a nida, as we just spoke about, from bleeding. But there are two main questions. The first one is, was there uterine bleeding? So if so, is it a wound or not? The second question is, how much cervical dilation was there? And the reason we ask this question is because there's a debate in the Gemara in Nida 21a that if the uterus opens, of course we know that it's the cervix that opens and not the uterus, but either way, if the uterus is open, do we assume that some blood came out? Or do we say, no, it's possible that the uterus opened without any blood coming out? So it's a debate in the Gemara. There's debate in the Rishonim. The Shulchan Aruch paskins that efshar l'ptichat hakefer below dam, that it's impossible for the uterus to open without there being dam. So without there being blood. So any time that the uterus is open significantly, then we assume that there was some blood, even if we don't see it, and the woman is deemed tamea, ritually impure. Go ahead. But the question is that when the Gemara has this debate, we presume that it was about a uterus that opened on its own, naturally, like internally. But what happens if the uterus is opened externally, if it's done via a procedure, such as a surgical procedure? How do we view it then? Do we still say, efshar l'ptichat hakever below dam, that we still assume that there was blood that came out? So this is, of course, also a controversy. We have the stringent view adopted by the Nod Yehuda, who says even an externally induced opening renders a woman a nida. The Aruch HaShulchan agrees, Rav Moshe Feinstein agrees. How wide does this opening have to be? There's a range of opinions. You should consult your halachic authority. A good idea to consult before you have a procedure so you know what's going on and what to anticipate. The Nishmat Psak is 19 millimeters. And in speaking with Dr. Orbuch, she said that her instruments never reached that wide. So that wouldn't be an issue, I guess, in her surgery as far as ptichat hakever. But another question that we have is where is the opening taking place? Is it just the internal os of the cervix, or is it the external os of the cervix? Now, in surgery, of course, you're going through all the way to the uterus. And for those of you who don't know, the cervix has depth to it. So the internal is on the side of the uterus and the external is on the side of the vagina. So the question is, what is considered uterine opening? So that's another halachic debate, of course. The lenient view from Rebbe Ovadia Yosef, based on the Tiferet Lamoshe, rules that only an internally induced uterine opening would render a woman a nida. So then a surgical procedure would not be an issue. But again, you have this issue of the cervical opening, but you also have the issue of the bleeding. So you kind of have to deal with both, just so you know when you ask a question what issues are at hand. So when you are planning a surgery, if you are going to go through with endometriosis surgery, really any gynecological surgery, very important to speak to a halachic authority in advance to know what questions to even ask the surgeon. Questions like, will the procedure make me bleed? You want to know what's happening. For how long will I anticipate bleeding? And where will the blood be coming from? Is it cervical blood, uterine blood, vaginal blood, outside, from somewhere else? Will the bleeding be from a wound or the body's natural response to surgery? That's a significant question in endometriosis surgery, in the laparoscopy, if I'm pronouncing that wrong.
Great job.
Okay, what size instrument will be inserted through the cervix? Because that's the question of the ptichat hakever. And at what point in my cycle will the surgery performed? Am I expecting my period at this time? And then we're concerned that maybe it actually is menstrual blood. So all of these questions should be asked in advance, and it can help a person prepare for what comes afterwards.
Great. Thanks, Jordana. So this is a perfect segue into the proper surgery, the gold standard of surgery for endometriosis, and it's called excision of endometriosis. So back to these endometriosis implant that I had spoken about at the beginning of the lecture, what excision is if this is an implant, literally excising or cutting out this entire implant. It's removing this inflammatory cells, as well as removing the implant that's pulling the anatomy and shifting it. So excision is cutting out the whole implant. And the reason that ablation or cautery is the wrong surgery and doesn't work is because it only treats on the superficial level. Now, I learned how to do the wrong kind of surgery in my OBGYN residency. I learned how to do ablation of endometriosis. It was only until my fellowship that I learned how to do the proper treatment. And I think this picture really hits home. Now, if this is an iceberg, endometriosis excision literally will remove the entire lesion, whereas ablation is just removing the superficial portion and leaving this whole deeper area that's really contributing to the bulk of the pain and setting off all of this inflammation, and sets off inflammation from head to toe. So we have great data to show that excision is better than ablation. The gold standard of data from a doctor is a prospective randomized double-blinded 5-year trial. And that's what we have that shows that excision of endometriosis is so much better than ablation. So people usually want to know, how do I perform it? What do I use? This is a pair of robotic scissors. And what's important is that the first surgeries tend to produce the best response. So if someone even suspects that they have endometriosis, I implore them to find someone and ask the right questions to find an excision specialist. So I want to orient you into a video. This is sort of like a similar picture that I had shown at the onset of our lecture. If this is the uterus in front, and the left ovarian tube, right ovarian tube. Here are the uterosacral ligaments that we saw in one of those pictures earlier on. And then here is the rectum. So this is a front to back picture: uterus, uterosacral ligaments, and rectum. And we're going to see an excision. This is the uterus, this is the right side, and this is the left side. And I'm going to come in with my instrument, and I'm going to lift up the right ovary. I'm grabbing the right uterosacral ligament. I'm utilizing scissors. And I don't know if you can appreciate that reddened area is endometriosis. And now the tissue is just going to give away because it's been pulled in because of the endometriosis. And then my bedside assistant comes in, they remove the specimen, and we send it off to pathology. Now, there was tons more endometriosis here. This whole area where it's all red, here is all endometriosis. This is more endo on the rectum. And then if we lift up this left ovary, there's a bunch of endometriosis as well. If anyone wants to see more videos, I'm happy to show them. I wanted to show what a uterine manipulator looks like so you can conceptually understand what Jordana was speaking to. So this is a front to back picture. This is a pubic bone, the bladder, the uterus, and the rectum. And my uterine manipulator, I use a Valchev manipulator. It goes in through the external os, internal os, and then into the uterus. And then that allows me to move the uterus anterior, posterior, and then it allows me and facilitates the excision of endometriosis. And, bleeding post-surgery can be from the uterine manipulator, but it also can be from the emotional stress or the physical stress of surgery that affects the regular rhythm of the female hormones. And anyone who's even had their tonsils out could find that their menstrual cycle is off for the following 2 to 3 cycles after having a tonsillectomy. And I just wanted to, throw in a few other thoughts because there's so much misinformation about endometriosis. Hysterectomy or removing the uterus is not the treatment of endometriosis. As we learned, endo by definition is found outside of the uterus. So why would we want to remove someone's uterus to treat a disease that's found outside or external to the uterus? We don't need to remove ovaries or castrate women. That doesn't treat endo. And pregnancy is not a cure for endometriosis, despite, again, what I was taught when I was a resident. And for those of you who are trying to find all the different passcodes to win some prizes, Beating Endo is our passcode. And we spoke about endo, and I know you're all experts on endo. I wanted to just very quickly touch on pelvic floor dysfunction, which JM also had. So back to my 4-year-old drawing. We have pelvic floor muscles, which is depicted here, and that's what holds our organs in place. This is a little more sophisticated picture, but what happens typically from, let's say someone has constipation. Typically, if we have a bowel movement, our muscles should relax here in order for stool to pass. But if someone's constipated, instead they're squeezing the muscles. The same too goes for the bladder. If someone has urinary frequency because they feel like they keep having to urinate, the normal physiology of relaxing the muscles around the bladder doesn't happen. And instead there's a contraction of the muscles. The same thing if someone's going to have relations and they've had pain or they're anticipating pain. Normally during sex, the muscles should relax, but instead if someone's having pain or discomfort or anticipating that pain, there's a squeezing of the muscles. So that's why I always refer to pelvic floor physical therapy. So finishing up the timelining to get MG better, when she came in for her consult, I suspected endo based on me asking her a whole host of questions and my physical exam. I set her off to start with pelvic floor PT, which she did for weekly for 10 visits. 3 months after I met her, she underwent excision surgery. 6 weeks post-surgery, she reported to me that I feel 80% better. And I have my patients continue pelvic floor PT within the first week of surgery and then continue it thereafter. 3 months after surgery, she was able to have sex without pain. And 5 months post-surgery, she actually achieved pregnancy spontaneously. This is the timeline that I saw when I finished my residency and finished my fellowship 17 years ago. It was a teenager who had pain, went to the pediatrician. The word endo wasn't spoken. The pain persisted. She, in her 20s, went to her gynecologist. Again, endometriosis was never mentioned. She started to develop GI manifestations. Again, full evaluation was done. No mention of the word endometriosis. She later then had urological symptoms, and same thing, no mention of endo. Another GI because symptoms were worsening. She now is newly married. She's experiencing pain with sex, and to which the gynecologist says, have a glass of wine before you have sex and maybe see a psychiatrist. Maybe you're depressed. She's not able to achieve pregnancy. She sees a reproductive endocrinologist or a fertility doctor who finally does make the diagnosis, but albeit does the wrong surgery. And then all of a sudden, close to 40, she has the proper surgery. This is why I do what I do. And I love to teach and I love outreach, because my goal and hope is that if there's a teenager who's having pain, she's going to go to the pediatrician. The pediatrician is going to know the different signs of endometriosis and steer that mom and her daughter straight to a specialist. Doesn't mean that we're jumping in and having surgery, but they're going to be armed with proper information. And when the time is right for that particular person, they'll undergo excision of endometriosis. And then that young adult is going to live their life in the fullest or for the fullest. I wanted to bring awareness to a great documentary called the Endo What documentary. This is the first movie of a series of 2 movies. The second one is finished and we're ready to deliver it. But just because of COVID, it hasn't been released yet, but look out for it. It's called Fighting in the Dark. And you can watch that Endo What documentary at endowhat.com. I mentioned Nancy's Nook Facebook group. It's a great online educational resource. a time, Yesh Tikva, Yoetzet Halacha fertility counselors. And you don't have to buy my book. There's so much information out there, and I've donated a bunch of books, and hopefully you can win it as during the raffle.
The link to Dr. Orbuch's book is also in our session info, so you can find it there as well. Okay. Dr. Orbuch, fantastic. Thank you so much. We have one question. We have a couple of minutes, so we'll take a question here. Someone is asking, does physical build predispose one for endo?
Not that I know of. If they're referring to short or tall, or now, no, I don't believe so. I've never been asked that question.
Okay. What about weight, like overweight, underweight?
No. I have thin, petite patients. I have wide patients, short, tall, every ethnicity, no.
Okay. Someone has another question. We have one more minute. What are fibroids? I know that's not your topic today, but in a nutshell.
Yeah. So fibroids are benign growths of the smooth muscle of the uterus. So of their growths that can be found in the lining of the uterus, in the muscle of the uterus, or on the external uterus. And they're pretty common. Probably roughly 30% of women have fibroids. And usually if you have one, you have many.
Obviously different than endo.
Very different than endo, yeah. Very common though.
Okay, amazing, great. And folks also want to know how to sign up for the book raffle. Oh, I'm not sure about that, but we did give you the code. I think it's like maybe if you go to the home area, I'm not sure, I didn't enter the raffle. But anyway, thank you so much, Dr. Orbuch. This was really educational. Thank you for teaching us about endometriosis. And as your message reaches more and more women and the medical community, we really hope that it will help women lead happier, healthier lives, and enable more couples to have happier marriages and eliminate a significant cause of infertility. So we really can't thank you enough, and have a good evening, everyone.
Thank you, Jordana.
Thank you.
Bye.
Bye.